So at this point, I will turn it over to Dr. Pavna Patel for intimacy and sexual health in Parkinson's.
Good afternoon. I will be talking about an important topic that probably doesn't get enough attention in an office visit. It's called intimacy and sexual health in Parkinson's disease. So I have no relevant disclosures to this presentation. However, I do have a couple disclaimers. I am not a sex therapist. I am a movement disorders neurologist. And I do want you to be aware that as part of this discussion of treatment strategies, there will be illustrations of the human anatomy. So today I will be reviewing why it is important to talk about sexual health and how does Parkinson's disease affect sexual health. And lastly, I will discuss some management options, including some practical strategies from patients and medications. So we'll review a few definitions to start with. Most of us know the definition of intercourse, sexual activity involving penetration. However, many of us may not know what outer course means. So outer course is sexual activity without penetration. And this can include massage, kissing, manual or oral stimulation. And intimacy is defined as the experience of strong feelings of closeness, connectedness, and bonding. So interestingly, sexual dysfunction is rated as a top 12 most bothersome symptom out of 24 in Parkinson's disease. And most of Parkinson's disease symptoms can affect the sexual response across all stages of the disease. So with that alarming number, how many patients do you think with Parkinson's actually discuss their sexual health with their doctors? I was shocked by this, but not very surprised. 49% of patients never discuss this with their doctors, 32% sometimes, and 19% always. So the benefits of sex and intimacy. So there's lots of benefits as depicted here, including both emotional and physical. So many times patients feel happier as there are different brain chemicals that are released, one including oxytocin as a result of sex. Different endorphins are released that can reduce stress, along with improving your own self-image. And there have been studies to show that there's been reduction in pain based on the release of the endorphins, along with better heart health, improvements in immune function, and just overall physical fitness. So why is sexual health important to discuss? So it does affect relationships. There have been some studies, including surveys, one where men with Parkinson's disease and their partners were reported to have greater marital and sexual problems. And young onset Parkinson's disease patients noted worse scores in marital satisfaction scales, and patients reported physical and emotional communication was reduced after receiving the diagnosis of Parkinson's disease. However, their desire for intimacy remained unchanged. Sex is important to people of all ages. There was one Swedish study that revealed 83% of men aged 50 to 80 stated that sex is important. And one US study of sexuality and health that included a little over 3,000 adults revealed that sexually active individuals did range from ages of 57 to 85. And the need for intimacy, physical contact, and affection does not subside with age. So how does Parkinson's disease affect sexual health? And this can be slightly different in both men and women. So in men, erectile dysfunction is commonly reported, along with premature ejaculation and difficulties with ejaculation. And in women, they may experience difficulty getting aroused, painful sex, and vaginal dryness. Both genders reported dissatisfaction with sexual life, difficulty reaching an orgasm. Many reported that they stopped having sex as a result of this, and reduced or absent sexual desire. 76% of men with Parkinson's disease reported experiencing these symptoms, and 78% of women with Parkinson's disease reported experiencing these symptoms. However, only 34% of patients actually discussed these sexual issues with their partners. So common sexual problems that are associated with the motor or movement symptoms of Parkinson's disease include tremor, dyskinesias, rigidity, stiffness, the bradykinesia or slowness, difficulty moving in bed, and the masked face. So tremor and dyskinesia can cause discomfort or get in the way, especially as sometimes these movements increase with excitement. Slowness and stiffness can make sexual activity more challenging. And the masked face, where you may look like sometimes that you're not as interested. All these motor symptoms can lead to impaired intimate touch, arousal difficulties, reduced ability to orgasm, loss of erection in the middle of sexual activity, need for changes in the sexual habits and positions, and a role change where patients become sexually passive, requiring the partner to have a more active role. And all of this can lead to a decreased frequency of sex. We reviewed some motor symptoms that can affect sexual health. However, there is a long list of non-motor symptoms that can also contribute to sexual dysfunction. For example, mood disturbance, depression, anxiety, apathy can lead to a decreased desire and can also contribute to erectile dysfunction. Certain medications can even cause erectile dysfunction or reduce your libido. Reduced body image or appearance may affect your self-esteem. Fatigue can affect your desire to have sex. Concentration and memory changes. Pain and sensory changes may also contribute. Sleep disturbance and daytime sleepiness, and sometimes patients experience acting out of dreams at nighttime, which may lead to bed separation, reducing the chances and opportunities for intimacy at night. Drooling and excessive sweating can also affect one's self-image, along with low blood pressure and lightheadedness and bladder dysfunction, particularly in women with urinary urgency or incontinence. Or even the fear of incontinence can decrease arousal in patients with Parkinson's disease. Again, all of these non-motor symptoms can contribute to sexual dysfunction. Along with reduced couple communication, this can also lead to increased relationship tensions, can affect the partner's sexual function. And like I mentioned earlier, bed separation, which may lead to decreased opportunities for intimacy. So how can we manage this? So I have a list of intimacy tips from patients and their partners, which can also be found on the Parkinson's Foundation website. So plan for sex when movement symptoms are at a minimum. This is very important. You can talk to your doctors about scheduling your Parkinson's medications prior to having intercourse or outer course. Apply oily lubricants to lessen the effects of tremor on the skin. Use sexual aids to increase pleasure for both you and your partner. Plan positions in advance with minimized movements between positions, and try different positions and find what works best for you, both you and your partner. Using lubricants for penetration during intercourse, and be sure to read the lubricant's instructions before you begin. Use satin sheets to ease movement. Perform intimacy training in erotic tasks. And reduce stress and burden on your partner. Keep expectations real and do not blame yourself. Try not to worry about an erection and just enjoy the physical intimacy you have with or without penetration. And this is where the concept of outer course is very important. Don't wait until bedtime, as fatigue at the end of the day makes it stressful. And similarly, if you have urinary urgency or frequency, you can also reduce any fluid intake 1 or 2 hours before you time your intercourse. Intimacy and touching can be outside of the bed as well, which is also very important. Find alternative ways to express caring, whether it may be massage or caressing each other. Consider starting off with a body massage. And using humor and communication with your partner is very important. With your partner, like I mentioned earlier, only 34% of patients who express sexual dysfunction communicated with your partner. This is one of the most important things you can do. Be playful with your partner and be honest about what you can and what you cannot do. Discuss new ideas with your partner and modernize. There are lots of different resources available now to improve sexual dysfunction. So Gila Bronner, who is a sex therapist, recommends investing in 4 different domains that are listed here: couple time, intimate time, sexual time, and personal time. Couple time defined as you spending time with one another, with your partner, in a very non-sexual way, whether it may be reading or walking, exercising, and rekindling the emotions that you once felt. Intimate time, including emotional and physical time, and this can include the outer course. And then sexual time and personal time, investing time in your own self to do things on your own and learning about what makes you happy is also very important. So I'll go into some treatment options based on specific issues that may arise in Parkinson's disease. So if you have arousal problems due to motor or non-motor symptoms, plan the sexual activity during an on time or when the fatigue is minimal. Discuss with your doctor medication dosing prior to sexual activity and choose a position that is comfortable. And consider use of sexual devices, which may be purchased online. For erectile dysfunction, which refers to difficulty with achieving and maintaining an erection. In addition to Parkinson's disease, it can actually be caused by vascular, psychological, or hormonal factors. Common conditions that can lead to erectile dysfunction outside of Parkinson's disease include diabetes, high blood pressure, prostate cancer treatment, high cholesterol, obesity, and even low testosterone related to hypogonadism. Sometimes patients can even have performance anxiety and relationship issues, which can lead to erectile dysfunction. If you have other conditions contributing to erectile dysfunction, the first line therapy is lifestyle modifications, such as regular exercise and weight loss if you are obese, or tobacco cessation, testosterone replacement if you were diagnosed with hypogonadism, and better control of other issues that may be contributing, like diabetes, high blood pressure, and high cholesterol. If you are diagnosed with hypogonadism, testosterone treatment may be an option. At times, there are medications that can contribute to erectile dysfunction. So talking to your doctors and reviewing your medications is important. If these things are addressed and you have erectile dysfunction, there are oral medications that you may have heard about. They increase your blood flow. That include Viagra, Cialis, or Levitra. You typically have to wait a minimum of 30 minutes to an hour from the dosing to sexual activity. However, what we've learned is that some patients with Parkinson's disease can have impaired gastric motility, meaning that the medication absorption may be delayed. So you may have to wait longer, even 2 or 3 hours. So if you do notice this, it is important to let your doctors know. However, if you do have certain heart conditions, these medications may not be an option for you. Additional options include intracavernosal injections. This also works by increasing the blood flow to the penis. It is administered on one side. Another option is called medicated urethral system for erections, which is an intraurethral suppository. You use an application which puts a dissolvable pellet into the urethra. Alternatively, there are vacuum devices which consist of a tube placed over the penis and it seals at the base with a lubricant. The pump helps bring blood flow into the penis to establish an erection before sexual stimulation. There is a relatively newer investigational treatment option, which is not routinely available at all practices, but can be part of a study, which is called low-intensity shockwave therapy. It is a non-invasive procedure where a healthcare provider applies a set of shocks per minute using a handheld probe. A session typically can last up to 20 minutes and repeated treatments may be required. But keep in mind, this is still an investigational treatment option. And lastly, if the oral and injectable and the intraurethral suppositories do not work for you, there is a third option, which is an implanted penile prosthesis. It is a medical device that is implanted in the penis during an outpatient procedure, and it is entirely concealed within the body. And lastly, if psychological or interpersonal conflict is the cause of your erectile dysfunction, addressing those issues is going to be very important with either individual counseling, marital counseling, and again, management of any underlying mood disorder, which may include depression, anxiety, or apathy. In women, there may be vaginal dryness, which may also lead to painful intercourse. Lubricants are recommended for this. There are different types of lubricants. There are water-based lubricants. These are the most widely used lubricants and available in stores. However, these dry out much faster and may not last long enough for the sexual encounter, so you have to reapply. Water-based lubricants can get sticky and uncomfortable when dry, which could also contribute to pain. Alternatively, a better option may be to use oil-based lubricants such as coconut oil or any other nut oil that can be found in any store. And a third type of lubricant, which is also recommended and may be better than the oil-based, is silicone-based. It feels silky and lasts longer than the water-based lubricants. There are petroleum-based lubricants, however, those are not recommended, which could include things such as Vaseline or baby oil. Additional treatment options for vaginal dryness and painful intercourse include avoiding penetration for a short period of time while the reason for the vaginal dryness is being addressed and some treatment options are being tried. So using outer course to avoid that pain that may accompany penetration for a short period of time. Hormonal treatment may be indicated, especially if you're postmenopausal. Again, following up with your gynecologist is going to be very important for that. Vaginal dilators may be used to help with vaginal stenosis or narrowing. Problems with orgasm. So difficulty with reaching an orgasm can mean either decreased frequency of orgasm, or you could have a reduced sensation or intensity of the orgasm. The most highly recommended option for this is sex counseling, where you can learn about different stimulation options. There are various devices available that can be purchased online. Vibrators can even be used to increase blood flow and then in turn to increase pleasure. Sexual positions. You can search online for ideas of various different sexual positions and find that one that works best for both you and your partner. Some of you may be hesitant to do this, but if positioning is a challenge for you, I encourage you to find one that is comfortable. Planning the time, that again, I can't emphasize this enough, planning the time with medications and when you feel like you are in your most optimal state with less fatigue and sharp thinking. And shifting the focus from orgasm oriented to pleasure oriented. not having the expectation of reaching an orgasm, but expecting that both you and your partner will experience pleasure in whichever intimacy form you engage in. And treating the underlying mood disorder, whether it may be anxiety, depression, or apathy. And counseling or therapy for yourself can also be important. For absent or reduced sexual desire, again, treating the source here is important, whether it may be the mood disorder, fatigue, pain, or a relationship problem. So some of you may actually experience the opposite, which is hypersexuality in Parkinson's disease. So this is defined as a marked increase in sexual interest, arousal, and sexual behavior with adverse consequences for the patient and their partner. This can be described as preoccupation with sexual thoughts, frequent demands, pornography, or even contact with sexual workers. It is classified as an impulse control disorder and can occur in up to 3.5% of patients. It's described most often with the use of dopamine agonists, medications such as Mirapex, Requip, or Nupro, but it's also been described with use of levodopa and DBS. So if you or your loved one is experiencing this, then you should talk to your neurologist as a medication change may be warranted. So who can you seek help from? So here at Fixel, we are big proponents on multidisciplinary care. However, the same thing applies for sexual dysfunction and Parkinson's disease. Multidisciplinary management is very important. This includes sex therapists who can actually guide you on emotional and physical aspects of intimacy, and you can learn different ways to maintain that intimacy as your body changes, as you get older and with the disease. Couples therapy or counseling is important to address any relationship issues that may underlie your sexual dysfunction, and the fact that there may be a change in roles where a partner may become a caregiver, and that can also impact your relationship. Counseling and mental health provider for yourself and addressing your mood and any self-image concerns that you may have. Physical therapy with specifically something called pelvic floor rehab. This is applicable to both males and females, where this is important to strengthen the pelvic floor muscles for bladder dysfunction and actually learning to relax those muscles to prevent pain. Urologists can help with the treatment of erectile dysfunction, and gynecologists can help for vaginal health, hormone replacement, and evaluation of vaginal stenosis to determine if any dilators are needed. So here I have a list of some great online resources. Please check out these websites. You can find physicians and therapists and counselors all over. Actually, some of these are all over the world, and some of these include a list of providers all over the country. So please look at these resources, and the AARP.org is also another good resource. And that concludes my talk. I will leave the screen up. Thank you for listening, everybody.